Neurodevelopmental disorders. The category of neurodevelopmental disorders are typically representing disorders that have onset during the early developmental period. So these are things that tend to show up most during childhood, but certainly have developmental and life impacts throughout the lifespan. So most of the diagnostic criteria for disorders within this section require you to have early signs of these disorders during childhood, even if these things were not diagnosed at first during childhood. And they typically include deficits in functioning related to multiple dimensions of functioning, including social, academic, and/or occupational, depending on the time developmentally that it's diagnosed. And these are frequently co-occurring with other disorders. Now, we won't be going over every single disorder within this category, but we will hit the main ones that you might interact with. It's important to note that as professional counselors, most of the disorders within this category are not something that we are able to diagnose fully on our own. They do require extensive testing. This often needs to be done by a combination of professionals, be it a psychologist, maybe a primary care provider, and other professionals with more extensive testing. So just a note there. So intellectual disability or intellectual developmental disorder, often referred to as IDD, is actually separate from autism spectrum disorder, although we see them commonly co-occurring with each other. And so this has onset during the developmental period, and you see deficits in two different areas, intellectual and adaptive. So to meet the criteria for this disorder, you need to meet all three. So there must be a deficit in intellectual functioning. This includes things like logic, reasoning, problem solving, abstract thinking, can be deficits in abstract learning and academic learning, but we would want to rule out specific learning disabilities as the cause for those, and to some degree, experiential things. There is also a deficit in adaptive functioning, which includes things like communication skills, social interaction, or understanding social cues, or challenges in fulfilling the tasks to live independently. So these are really about everyday living skills as opposed to learning intellectually. And these things need to be marked below developmental and cultural standards based on their age across multiple environments. So they're not just doing poorly at school, but they're struggling at school, work, and home. And so these, again, have to have onset during the developmental period, just like every other disorder within this category. And so it's important to determine the benchmarks or the typical level of functioning for your client in these domains. And so there's often a question about why these things happen. Why do people develop ADD and or autism? Some of them are pregnancy-related issues, genetic factors. Those account for these changes about 25% of the time, and they're considered something related to environmental factors impacting development. So these can be complications during pregnancy. These can be the result of physical harm, emotional abuse, or other mental disorders, but a lot of times there's not really one identifiable cause that we can point to. This disorder impacts about 1% of the population, and it's more commonly diagnosed in boys than girls. So noting that there are different levels that are used to identify where someone is in terms of IDD and how much it impacts their functioning. And this really has to do with adaptive skills, not necessarily an IQ score. That's a bit different. So we have mild, moderate, severe, and profound, and this is how much the symptoms are interacting with daily life. So someone who's more in the mild to moderate range, there might be some delays in development. They might need to be potentially in a special education classroom, but they're largely independent and able to do things on their own. So they may be a bit slower in progressing or in developing communication skills. And moving into the moderate category, we need some considerable supports in terms of decision making and independent living, but still able to function for the most part. These individuals are able to walk, able to talk for the most part, able to, with some supports, live really interactive lives, go through education settings, be able to get jobs. Now, someone who's more in the severe category, you see little progress or change in their skills and language beyond those early developmental periods. And they require a great deal of support and supervision for pretty much anything. So these are individuals who struggle to talk, who struggle to function, may not necessarily be able to navigate basic hygiene skills or things like that. And then moving into the profound category, these individuals don't develop much past that early period. So they have very little understanding of language, really struggle with making social connection, and they're pretty much completely dependent on others for daily life. Noting that children under 5 are not really able to be assessed reliably because of developmental considerations. So we don't really see these things diagnosed younger than kids maybe 5 or 7 years old. The current evidence-based testing for intellectual disability doesn't recommend use on children under 5. And so we can use the diagnostic category of a developmental delay until children get a bit older, and then when they turn 5 or 6, they can be assessed appropriately for IDD and or autism. And you'll see throughout the DSM that there are a number of disorders that are somewhat sequential. So you have something that's available to be used when someone is a bit older, or perhaps when a symptom hasn't been present long enough to meet another criteria for another diagnosis. And so that developmental delay diagnosis is sort of the precursor to IDD and or autism that we can use until children can be assessed properly. So moving on to communication disorders. These are disorders specifically related to language and communication. So these are deficits in areas of speech, language, and communicating with others. With these, you want to look for family history because there is a strong genetic link to developing these. These are not the same as learning disabilities, but they are commonly co-occurring. So we see these often in conjunction with learning disabilities. So for communication disorders, we have language disorder. This is marked difficulty with learning using language in multiple modalities. So it's not just an issue in speech or written language, because those might be more indicative of a learning disability. This is communication issues related to speech in general. So we can't use language or understand language in general. So it's comprehensive. We're looking for evidence of reduced vocabulary, both knowledge and use of vocabulary, limited use in being able to put language into sentences, impairment in being able to explain things in conversation with others. And obviously, this is not something as a licensed professional counselor that you would diagnose by yourself. There would need to be some other developmental testing involved, but it might be something that you recognize and then refer parents to additional testing opportunities or referral to other professionals to see if that's what's going on. We would look for marked language ability substantially below their age group. And in terms of these types of developmental disorders, we're looking at comparison within grade level. And so your functioning is limited in relation to communication in multiple areas in relation to children about at your age in your grade level. Again, we see that onset during the early developmental period, as often as early as preschool, which is kind of when we start playing with phonics. We get hooked on phonics, if you will, and start working with some language. And then, of course, we're going to want to rule out any kind of physiological explanation. So we want to make sure that the child's not having hearing issues, like they're not able to communicate properly because they can't hear well, or they're not having some sort of sensory issue that's getting in the way of them being able to focus enough to communicate verbally or to be able to read. Making sure there's no problems with their eyes and being able to internalize and read. Also looking for evidence of perhaps brain injury that explains inability to internalize information. So we always want to rule out any kind of medical or neurological issues and make sure that this language disorder is not just indicative of a larger diagnosis of something like intellectual disabilities or just a general global developmental delay. So again, we might need to use a conjunction of disorders and diagnoses as a child goes through development to see how long these symptoms stick around. Now, another option in terms of communication disorders is speech sound disorder. This is specific difficulty with making speech sounds. So you might hear a lot of garbled speech or no verbal communication whatsoever. It's the difficulty in translating things in your head to things that come out of your mouth. And so there's limitations that then interfere with your ability to connect socially with others, to participate effectively in school, and or ability to do occupational things related to maybe like playing or doing things that are developmentally appropriate in terms of engagement. Again, we see that onset during the early developmental period. We may not see this one until someone is maybe 7 or 8 years old. They're a little bit older, but still that early developmental period. And we want to make sure, again, it's not related to any kind of physiological issue. There's not something going on with someone's mouth, so they don't have like a tongue tie or a cleft palate or cerebral palsy or things that involve muscular use of the mouth. Want to rule out any kind of hearing issues, traumatic brain injuries, or neurological complications. You also want to rule out the possibility of selective mutism. That's not uncommon with children who've experienced trauma or anxiety. When you are little and you can't control a lot of things, the things you can control are what you say, who you say it to, and sometimes you choose not to say anything because it feels the safest. And so you want to make sure it's not really more indicative of trauma or an emotional issue. It's a difference of, can you understand and communicate via speech and you're choosing not to, or you really don't understand how to translate the things in your head into spoken word. Another option is child onset fluency disorder, noting that there is a separate disorder category for adult onset fluency issue. We often call this stuttering. And so this is also different than Tourette's or a tic-related disorder, and we'll want to rule that out as well. So in terms of stuttering, there's difficulty in fluency and pattern of speech. And again, we're comparing this with grade level. So looking at grade level appropriate language skills. And so there has to be one or more of these indications of a stuttering issue. Perhaps it's repeating of syllables. Perhaps it's prolonging words and syllables. So saying them longer than would be naturally in a pattern of speech. Looking at broken words or long pauses in what someone's saying. Silent blocking, so pausing in speech or stopping because you're not able to continue. So these are a different type of pauses within speech. So you're either pausing in words and breaking them up, or there's long pauses in between words as you're speaking. You also are looking for word substitutions to avoid words that are common for stuttering. And so this might be stopping mid-sentence and changing words because you know that you're about to stutter, or it's a word that you stumble on a lot, or just noting a lot of stress and tension in speaking in the first place. Again, a lot of this is indicative of trying not to stutter. And then there might just be a lot of repetition of syllables. So this leads to naturally anxiety about speaking or limitations in communication because of that difficulty. So seeing individuals avoiding situations where they have to speak in public or avoiding social situations because of that. Again, we see that onset in early development, and we want to rule out any physiological cause. With stuttering, this might be evident as early as the age of 6, and sometimes we see it start small with a gradual onset that gets more severe as you get older. The next is social or pragmatic communication disorder. This is really struggle in social situations in verbal and nonverbal communication. And with this, you really want to rule out autism spectrum, you want to rule out IDD, and you want to rule out social anxiety. So is it a deficit in the ability to communicate, or is it anxiety that's preventing a child from communicating effectively? So this is a child that perhaps interrupts a lot. They have difficulty taking turns. They have struggled with verbal and nonverbal communication, and there's different contexts. So we might look at indoor, like not understanding indoor versus outdoor voices. So the kid who's really loud all the time and they don't understand why it's a problem, or understanding the difference in speaking to a kid versus speaking to an adult. Also, this might be the kid who just does not understand sarcasm. They don't get metaphors. Everything's very literal. And again, we want to rule out autism spectrum and IDD in thinking about that. And we want to make sure that it's not just related to a lack of grammar or language comprehension. It's really related to difficulty in connecting socially through language. So talking about autism spectrum disorder, so we used to have Asperger's and we used to have autism. They evolved and were put together into an autism spectrum disorder. We also had this idea that you either have autism or you don't. And now we have this idea of a spectrum where there are very functional folks with more mild autism disorder. And then there are folks with more severe autism disorder that impacts more areas of their life. And so there's a big debate and discussion about why autism is more common. And then there's also a scholarly discussion about, is autism really more common, or do we just have better criteria now to capture all the folks that had autism all along? We just didn't have broad enough criteria to capture all the different ways that it shows up. So criteria here are based on either current behavior or history of behavior. Again, it needs to show up within the early developmental period, noting that it's not the same thing as IDD, but they commonly co-occur or happen together. Overall, autism impacts about 1% of the population. And again, there's argument that it's the same number of kids that always had autism. We're just able to capture and diagnose them earlier in life and be able to capture a broader range of symptoms. We might see these symptoms show up as early as 2 years old. We're not really able to test for autism prior to that, and usually the things that you see earlier in life are connected to delays in language. And so there is research that supports somewhat of a genetic link to autism or genetic mutation related to autism, but we don't really have a clear picture of why this happens. We do have a clear picture that it has absolutely nothing to do with vaccines. So just to discount some rumors in the research community about vaccines causing autism, there really is no research-related link in those things. So in terms of autism spectrum disorder, you see persistent deficits in social communication and interaction across multiple domains. This is related to social emotional connections and understanding and sharing of emotions, nonverbal communication in the way of interpreting and showing things like body language and eye contact, and then also in being able to connect meaningfully and develop relationships with peers. So there's a lack of interest or ability to connect socially and understand others. There's also restrictive patterns of behavior. So this is one of those categories we need to show multiple symptoms. And again, this testing is rather extensive to make sure all of these things are present. So you might see repetitive movement, speech. We call this something like echolalia, where they're just repeating back something else, or just repeating the same words over and over and over again. Inflexibility, needing things to be the same. I need to eat the same food on the same plate every day. There's ritualized patterns of behavior. We always want to rule out things like obsessive compulsive disorder with this as well. Fixated interests. So I love trains. I want to know absolutely everything there is to know about trains, and if it's not about trains, then I'm not interested in it. And then kind of one of the hallmark things of autism is related to either overreactivity or underreactivity to sensory input. So sounds, colors, lights, etc. Sometimes the environment is too much, or sometimes it takes a lot of stimulation for you to recognize something is going on. Similarly, this also has to show up in the early developmental period, but it may be a gradual onset, so we may not see it fully manifested until you get a little bit older and you see individuals really connecting more socially with others. And it has to cause clinical significant impairment across dimensions, not better explained by IDD or just a general developmental delay. So you want to look at multiple sources of information: primary care physician, ruling out any kind of physiological explanations, talking to caregivers, getting self-report if you can from the individuals, or at least observation, talking to teachers, and then ruling out things like mutism, obsessive compulsive disorder, just having some sort of learning disability or some other causes. And it's different from IDD in that IDD includes intellectual skills being impacted. Autism is mostly focused on social communication, sensory issues, and connection with others. So there's not as much focus on the intellectual domains. Looking at the severity levels, it's a little bit different with autism. So we have level 1 through level 3. Level 1 needs some support, but this individual can connect and function mostly independently with some capacity of support, but not all the time. Level 2, you need pretty significant support, but you have a lot of deficits in the social category. And then level 3 is the individual who needs support and supervision pretty much all the time. Okay, so hang in there. There's a lot of disorders in this particular category. So next we have ADHD. So historically we had 2 diagnoses. We had attention deficit disorder and we had hyperactivity disorder. These have been combined in the DSM-5 to attention deficit and hyperactivity disorder, commonly referred to as ADHD. So there used to be multiple types. We still see that with the current diagnosis. They've just changed a little bit from the DSM-4 and the DSM-4 text revision. With ADHD, you always want to rule out oppositional defiant disorder. So this is not happening just because they're trying to show defiance or hostility towards authority figures. You always want to rule out social anxiety, and you want to rule out side effects of medications. So hyperactivity is not an uncommon side effect for a lot of mood-related medications for kids. So we want to make sure that this is not something that's only showing up within the context of them taking some sort of medication. So with ADHD, we're looking at persistent patterns of inattention or hyperactivity and impulsivity. With the inattention, we need 6 of these, and now we have criteria to diagnose this as adults. It used to be that you could not diagnose ADHD in adults. There were only criteria for children. Now we actually do have criteria for adults to be able to diagnose with ADHD. So we need 6 of these criteria for kids. We need 5 for adults, and they need to be consistently present for the last 6 months and show inconsistency with developmental levels. So thinking about if your 4-year-old's kind of hyper, but they're hyper in a way that's typical for another 6-year-old or 3-year-old or however old your child is, then it may not be ADHD. It may just be typical childhood development. And we see negative impact with their ability to focus at school or be successful in the things that they're doing. So we see a lot of things related to failure to give attention to detail, making careless mistakes, difficulty in tasks or play that require them to have attention. So this might look like them getting really frustrated with like building a Lego set or something and giving up really quickly. Not able to listen when they're spoken to because it's just too hard to pay attention to listen to instructions. And so they maybe don't follow through with instructions. They don't finish their homework or their chores because they just can't pay attention long enough to do that. Hard with anything, difficulty involving anything with organization, not liking things that take a long time. So you might see a lot of adversity to doing homework, doing reports, trying to read, those kinds of things. Losing stuff all the time, easily distracted, and often forgetful. Then we have criteria related to hyperactivity and impulsivity. So here again, 5 for adults within the last 6 months, inconsistent with developmental expectations. So this is like fidgeting. This is the person that's always tapping their foot or can't sit still, or they're always squirming and have to mess with something. Again, we want to make sure that's not the same as self-stimulation related to some sort of intellectual disorder. Someone who leaves their seat when they're supposed to stay seated because they just can't sit still for very long. They run or climb, or with adults, this is someone who feels restless when they have to sit still for a while. Unable to play or engage in things quietly, so they have to make a lot of sounds, or they have to sort of indulge their need to make sounds as they feel it. Someone who's often on the go or described as if they're being driven by a motor. You'll see lots of versions of it's hard to stay still for a long time. They talk a lot, they talk quickly, they might be pressured speech, they can blurt out things because they can't wait for someone to stop talking, or they can't wait for questions to be finished before they answer. And they often have difficulty waiting their turn. They do a lot of interrupting. So ADHD, these symptoms typically present prior to the age of 12. However, noting that they're commonly underdiagnosed for girls. So ADHD we see more commonly diagnosed in boys, which doesn't mean that it doesn't exist in girls. It just means that it's not recognized as early in the developmental period for girls as it tends to be for boys. And so we see this interfering with their ability to function across multiple domains, and not due to some sort of psychotic disorder or hallucination or other mental disorder. We see a lot of hyperactivity earlier in like preschool age, and then the inattentive comes in a little later when people get into school settings. There's not a lot of evidence for a strong genetic cause, and we have specifiers that give us options in terms of severity, and if there's more predominantly inattentive symptoms and not as many of the hyperactivity, or vice versa, we have that option. With learning disorders, we're not going to get into too much information here, just noting that there's a history of impaired learning, and this impairment in things like reading is known as dyslexia. It's not often called that in terms of diagnostic criteria, but that's what it's commonly called. So there's different types of learning disorders related to reading, writing, and math. And these are considered keystone academic skills. So we're noting difficulty in using academic skills for at least 6 months that are below the expectations for chronological age and grade level. So we want to rule out things like IDD and autism, any kind of physiological explanation, or ADHD. So is it an issue with learning or an issue with attention? And so we see struggles in one of those sort of key academic areas of reading, writing, or math. Again, more commonly diagnosed in males, impacting 15 to 20% of kids that we see in school settings. With learning disorders, we do have different levels of severity. Specifiers can be used for certain skills. So it's not overall like IDD, it's not all learning, it's just one specific skill. So I do fine in everything else, but I have trouble just in math. And so then even students that qualify for gifted and talented can still have a learning disorder, because you can be really strong in another academic area and have a deficit in just one skill. These difficulties can change with age and supports throughout the lifespan, but because of a combination of genetic and environmental factors, we do often see family patterns in terms of learning disorders. talk about tic disorders. So these are persistent and they're either motor or vocal tics. These tic disorders are sudden, rapid, recurrent, either motor movements or vocal movements. And there's an example clip just to give you some examples of what this looks like. It can be different than stimulation, self-stimulation that's used in IGD and autism. So we have Tourette's disorder, which has multiple motor and at least one vocal tic present at some time. They don't necessarily have to be at the same time. And tics can wax and wane in frequency, but they need to happen for at least a year. And we do commonly see that when individuals have higher anxiety or stress, the tics become more consistent or they become more severe. But this has to be present at some point before the age of 18 to meet the criteria, and it can't be explained better by substance use or medication side effects. Then we have chronic motor or vocal tic disorder, at least one or the other, but not both. So that's the difference here. With Tourette's, you have motor and vocal tics. With chronic tic disorder, you have only one of those, with otherwise the same criteria. And then provisional tic disorder, at least one of those things, and this is the precursor to our other tic disorders. So if something's been going on less than a year and you don't meet the criteria for Tourette's or for chronic tic disorder, you can use the provisional tic disorder diagnosis to treat and monitor that individual until that period of a year has passed. Impacts about 3 in every 1,000 kids, again, more commonly diagnosed in males, and we see these change situationally based on social settings. So again, with higher anxiety, stress, sometimes getting excited, or even interaction with teachers or authority figures, we see the tics becoming more severe or more present, but that doesn't mean that they don't have the disorder otherwise.